What's up, everybody? This is Dr. Zach Baker, and you are listening to the Strength and Knowledge Podcast. Today, I have with me Dr. Tyler Betteridge, one of our sports residents in our Germantown location, and he has for us today his most recent journal article review, and it is geared around Achilles tendon ruptures. And Tyler, do you mind giving the audience just the title of the article that you chose and why it stood out to you or why it was of interest to you?
Sure. So the article I chose for this month was Non-Operative Functional Treatment for Acute Achilles Tendon Ruptures, the Leicester Achilles Management Protocol, otherwise known as LAMP. Reason I picked this was because during my clinical rotations, I had one patient who was a non-operative Achilles tendon rupture in the very acute phase. I also have two patients on my caseload currently who are non-operative Achilles tendon ruptures. And something I've seen across the board is that the protocols that we receive as physical therapists are either very brief or non-existent, very nondescript. So I wanted to kind of delve into this, any kind of studies surrounding this injury presentation and see if there was any kind of definitive protocol for managing these patients both in the acute phase and later on down the line throughout their rehab.
Perfect. You had mentioned it's sometimes or oftentimes we don't get much information that comes with the patient. And I look at that in two different ways. Part of it, and in your case, is because we do have a pretty good track record and a pretty good history with the orthos and the physicians in our area. They know how we treat. They know how we function. They know that we are aware of what protocols are out there. So oftentimes they will send patients to us just under the assumption of follow what a standard protocol looks like. And this would be an example of that. That can be pretty daunting, though, if you're a new clinician or if you just haven't had a very large sample size of that specific injury or of that specific protocol. But I do look at that twofold. Sometimes when patients don't come with much, it usually means that there is something standardized out there. It's just assumed that that's what you should be using. And if you're unaware of that as a clinician, that's kind of your hint to do a little research, do a little digging, and see what is out there. Tyler, do you mind go through the article for us and just give us a little layout of how it was designed, who was in it, and what the interventions were?
Sure. So 442 patients with acute Achilles tendon ruptures were treated non-operatively with the LAMP functional dynamic treatment regimen. 234 of these patients were also available for a 12-month follow-up and were used as a secondary analysis of outcomes. 77 of which were actually available in person for some objective measurements to compare their affected leg to their unaffected leg. We'll get into those objective measurements a little bit later on. As far as the actual interventions that were utilized in this study, the main point one of the main points in this protocol is the progressive heel wedge height and weight bearing protocol over the course of 8 weeks, and then also gave some recommendations on home exercise program interventions to include to send patients home with. It was noted in the study that the first cohort of patients in this study were only given the weight-bearing and wedge protocol as well as the home exercise program. But after the first cohort, all other cohorts of patients were also followed up with an intensive and recurring physical therapy regimen to supplement the protocol.
Cool. And just for those unaware, with the LAMP protocol, you do have a progressive heel wedge removal, which goes from 0 to 4 weeks where you're locked in up to 30 degrees of plantar flexion. 4 to 6 weeks, you go 15 to 30 degrees of plantar flexion. 6 to 8 weeks, 0 to 30 degrees of dynamized plantar flexion. And then 8 weeks, you get the boot removed and give an Achilles tendon strengthening protocol. Then discharged to the care of a PT 2 weeks post completion of the LAMP. And then there's an Achilles tendon strengthening program that consists of some isometric exercises for 10 reps. Didn't really give details of what those isos were, but there were isometric exercises. They're doing active range for dorsiflexion, plantar flexion. They're doing seated heel raises, and they are instructed to walk outdoors in comfortable footwear for 10 minutes. So the big thing with this is they're given a home program. They're given progressive range of motion limitations or guardrails that are either locked in place with the boot, and then they're also given some degree of weight-bearing status as well. So, Tyler, going through this, what were some of the outcomes that they found?
Sure. So, unfortunately, 208 of the patients were lost to follow-up.
Wow, so it's like half of the cohort they lost.
Right, exactly, yeah. They also identified 26 patients as having episodes of symptomatic venous thromboembolic events, 25 DVTs, and 1 non-fatal pulmonary embolus. But 7 of these patients were diagnosed with a VTE prior to treatment. They had 9 re-ruptures, 2%, which is 2% of the cohort, all occurring within 3 months of completion of treatment. And then in their secondary analysis at that 12-month follow-up for those 234 patients that were available, they looked at the ATRS, the Achilles tendon rupture score. That's basically a 10-question outcome measure graded on scale of 1 to 10 for each question, max score of 100. They found that the mean ATRS score at that 12-plus month follow-up was 75.5 with a mean follow-up of 23 months post-injury. They also noted that men had a significantly higher ATRS score as compared to women in the cohort. As far as the objective measurements that were available for 77 of the patients who came in for an in-person follow-up, they measured calf muscle girth, which they standardized as 10 centimeters below the popliteal crease. They measured 38.3 centimeters in the affected versus 39.2 centimeters in the unaffected leg, which they deemed as statistically significant. And then they also looked at heel raise height of the affected leg compared to the contralateral leg, which they measured as an average of 8.5 centimeters in the affected leg versus 11.01 centimeters in the unaffected leg, also a statistically significant difference.
Cool. So to summarize all this, it's a relatively low re-rupture rate, only 2%. And admittedly, I don't know what I was thinking would be normal or expected, but I would have imagined it would have been higher than that. Now, we did lose a good chunk of people from the original parts. I don't know if that number would have been higher had everybody responded, but that's still a relatively low number for conservative management. The other thing to note, functional results were improved, and they were better for the group that went through PT as the group that did not go through PT, which, if you're a physical therapist listening to this, pat yourself on the back because it means you have a place when it comes to Achilles tendon ruptures and the management of them. With that ATRS, that Achilles tendon rupture score, it was very comparable to the SMART protocol for Achilles rehab as well. But the LAMP and the SMART study both had a lower score compared to individuals if they were to get the Achilles tendon actually repaired. So we can have success with conservative management, but there is some research. There is research out there that shows surgical intervention does provide very good results for this as well. Obviously, just a longer process in regards to recovery, and most likely dependent on what your outcomes are in regards to functional status moving forward with this. Tyler, any other big takeaways in regards to summarizing some of the results? And then I'd love to get your thoughts on just what were your clinical takeaways and how you will utilize this in practice.
Sure. Well, just kind of circling back to your point on the re-rupture rate, the article did note a previous study that looked at re-rupture rates in non-operative versus operative patients. And they did note that in that previous study, they did observe a higher re-rupture rate in patients who opted for the non-operative treatment when they have more than a 10 millimeter gap on ultrasound imaging with that rupture. But they also noted that study was only a cohort of 45 patients, so not as big a sample size. As far as our ATRS score, that was, as you had mentioned, they looked at the SMART study, and that was comparable. And then they noted that the differences in objective measurements, so the calf muscle girth and heel raise height, though they were statistically significant, the study noted that the difference was very small, and it didn't necessarily correlate with their ATRS scores, indicating that those measurements may not be clinically significant.
And what do you think about when you get into the clinic and you're going to be working with patients? What do you take away from this? What's relevant from this article, especially for some of our younger clinicians or just individuals who haven't worked with conservative management of an Achilles tendon rupture?
Definitely. So, looking at the protocol, those initial first 4 weeks, they're locked in 30 degrees of plantar flexion with non-weight bearing status. So allowing the kind of rupture to scar down and let the attachment point kind of solidify before moving into weight bearing status is very important. And then having a graded heel raise height so that we're not overstretching the gastrococcaleus complex and allowing a gradual return to full weight bearing with normal gait is very important. Additionally, I think that this study is good from just patient education standpoint, looking at those ATRS scores. So the mean ATRS score is 75 out of 100 at that average of 23 months follow-up. So when we're talking to patients and they're considering operative versus non-operative treatment, being able to educate them on, what is our expected outcome from a course of physical therapy. So assuming that you are at 100% prior level of function prior to injury, you can educate your patients that they're going to be around maybe 70 to 75% of their prior level of function if they do decide to go the non-op route. Some of the other literature that I've read is that outcomes are favorable for people who are not planning on getting back into high-impact sports. If your only goals are to be able to kind of do ADLs and maybe go for hikes and do non-impact physical activity. However, I've seen that outcomes are not as favorable in people who are trying to get back into some recreational or competitive athletics.
And I think if you're a younger clinician, keep in mind that there are protocols out here for conservative management of this issue. So if you are not presented one by the physician that you're working with, you have this protocol that you can go off of. Keep in mind, we have a rupture of contractile tissue. So the things that are going to stress that tissue is lengthening of it. So we need to have some sort of structured game plan as to how we're going to reintroduce length. And that's what this will walk you through. Week by week progressions of what range of motion restrictions are so that we are allowing optimal healing and then progressive lengthening that is going to be safe and not catastrophic. The other thing we need to keep in mind is that contraction is going to irritate, or not necessarily irritate, but stress this tissue. So not only resistance training, but ADL such as walking and weight bearing is also going to combine for some stress on that area. So we need to be mindful of what we're doing from a mobility standpoint. We need to be mindful of weight-bearing progressions because a lot of your weight-bearing progressions is not only going to provide resistance, but also some of those positional demands of lengthening the tissue. And then we also need to make sure that we're looking at the volume in how we're doing that. And it's one thing just to restrict somebody with the positions they can weight bear in, but we also need to be looking at things such as like their daily step count or the duration that they're on their feet as well. And then keep in mind, what is your end goal? You had mentioned patient education on this. And are these individuals somebody who are just trying to get back to ADLs, or do they have higher functional aspirations? And if so, then that's a conversation they should be having with their orthopedic to figure out, am I a good candidate for conservative management, or should I be looking into surgical interventions as well? Tyler, appreciate the time and the efforts on this article. I look forward to what you come up with for the next journal article. If you've enjoyed this episode, please share, like, and subscribe. You're listening to the Strength and Knowledge Podcast. This is Dr. Zach Baker, Dr. Tyler Betteridge. Thank you.